And we're up. Okay, so thank you for the opportunity to speak to you today. And I'm going to speak to you about opportunities for big data in disease mapping, which is the thing that I spend most of my time and have spent most of my career doing. Alternatively, the second take on this is, how do we map all diseases? And that's the question that I'm going to pose to us today in the next 18 minutes or so, and hopefully give you some solutions to that and let you and come away with the idea that I feel that big data has a big part to play in solving this particular problem. So first, I'm going to have to tell you about the existing limitations of some of the geospatial techniques that we use, and particularly in gathering occurrence data to fuel that process. Then I'm going to talk to you about the known knowns, if you like, the infectious disease mapping targets that are out there, and perhaps illuminate to you a problem that you're not so aware of. I'll talk a little bit about ABRAID, and I'll explain that acronym as we go forward, and then talk about where I think big data can fit into that, and then just talk very briefly about how we've managed to speed things up in this process, perhaps as a pathfinder or a prototype in this area with the latest Zika public health emergency of international concern. So first off, I'm going to take a little bit of time with this particular slide because it explains to us how we use occurrence data in geospatial mapping. So have a look at the 5 different slides here, and they have an A, B, and a C, and a D, and an E with them. And our outcome is E. This is what we're trying to get to, a continuous map of the risk of a particular disease across the planet. And this example that we work with here is dengue, and the reference is in the bottom right. But the schematic, the way that we do this, is the same for all diseases for which we have occurrence data for. Now, B is our fuel, and we'll drill into this in another slide in a moment. So this is points on the Earth that we have a lat long and a time associated with, and a diagnostic for a particular disease. These are our occurrence points, and I'll use that term a lot. D is our environmental covariates, and essentially what we're trying to do with all the places that we have the occurrence of a disease is try and match the environment, be that rainfall, temperature, or vegetation, or population density, or many other socio-demographic variables that we have continuously across the planet. We're trying to measure those conditions where we know occurrence is, and then predict continuously across the whole world, and say for a place where we haven't got a sample, what's our probability of finding the disease there based on where we have observed the disease in the planet. Now we need C, and C is our control data, because people very rarely report absences. If you go to a place and you sample for something and you don't find it, it doesn't often come up in the literature. So there are whole schemes of essentially case controls that we need to make to get our sort of counterfactual, the area where the disease doesn't occur. And A is also entirely important in this process, and is something that may surprise many people in the room across many of the diseases, is that if a species modeling technique is blind to the distribution or the biogeography of a particular disease, it will extrapolate to all areas of the Earth because it doesn't have any constraints. So we need to also provide that constraint, which we call the definitive extent, which is simply a measure of the probability that we think the disease is in that particular location. Now I'm going to go through all of these bits in a little bit more detail, but the fuel for our analysis is A and B. D is relatively easy to get and assemble in large data banks. And when we bring all of those together, and we use a technique for species distribution modeling called boosted regression trees, but there are many out there, that's unimportant for this talk, we can make the continuous map, in this case of dengue, in E. And I am now going to say what some of the problems are in that particular process. The first is actually getting those occurrence data. So it's a huge effort, although they're all freely available. And we formally search the literature, PubMed, ISI, Web of Science, ProMed, etc., and identify all of those papers and read all of those abstracts, and then take from those papers and manually geoposition the occurrence of each one of those points. So for this dengue exercise, that yielded 8,000 or so points from more than 100 countries over the time period that you can see, and took us about a year to do. We also, like the Predict project, collaborate very strongly with HealthMap, and they have a system which is a more automated retrieval of those data, and we're able to provide another 1,500 points from their digital archives. So it took us about a year to do this for dengue. And just why do we want to do that in the first place is what this occurrence data is showing you. At the global scale, at this map, it looks like we have very good coverage in the Americas and Asia from this occurrence, and merging with the health map data, about 10,000 points in all. But you can see our coverage in Africa is very, very poor. So there's the clear rationale to map there. We want to make some assessment of risk in places where we haven't sampled. But actually, even if you drill into and it's a problem of showing these types of data at the global scale, if you drill into the Americas or you drill into Asia, you'll find there are large parts of there which are undersampled too. So this is why we want to make those continuous maps in the first place, and this is the problem set. It's very, very hard to get those data in the first place. So I've just set that video off and just look at some of those diseases as they go through. It's alphabetical and there's 350 of them, so we're not going to get through it, I warn you that now. But it's just to let you see the resolution, the geographic resolution of knowledge that we have for most infectious diseases, the known knowns. And this comes from the Gideon website, which is a fee-paying service for physicians, which you may or may not know about, and is what I think is probably the most comprehensive assessment across diseases that we have. Now, if you pick on some of the diseases that you might well know, Ebola, for example, it would be a good challenge for some of the physicians in the room to see actually how many of these 350 you recognize. Many of them I still don't. But the point is that most of the knowledge here is at national level, and it's not geographically refined. And if you look at diseases that you know particularly well, it's not comprehensive either. So in previous reviews that we've looked at, there are about 1,400 infectious diseases ever recorded. And from our previous talk, we can see that there are many more that we might want to worry about. And there are about 350 on fee-paying services like Gideon that there's an economic rationale, if you like, for people to collect information on. If we want to map any of those in a comprehensive way, we have to think about if the disease has spatial variants, whether we know about its life history, and for many of them we still don't, whether there's any information on this disease that we can map, and also whether it is actually of big public health interest. So what we'll move on to now is a review that we did of those 350 diseases and said, of what infectious diseases out there do we have, so of that 350, on those 4 criteria that I just showed you, is there a public health rationale, is it spatially variable, do we know its life history, etc. Of those diseases that we think it would be possible to map, which turned out to be 176 of that 352, what have we actually done? So we reviewed all of them, looked at the maps that had been made in that space, and the circle here, you're not supposed to be able to read all the 176 small bits of text which relate to 176 different infectious diseases. But if you had a black line from the center of the circle all the way to the edge, that means that you've mapped it as well as you can with the data that occurs in the literature. If it's a light gray line, then you haven't done or maps don't exist, or you haven't done a good job with the data that's available. So the big open space is the landscape for opportunity with this 176 known diseases that we think we could do something about with the information that's available. Now, given it took us a year to do dengue, and we're looking at 176 here out of 352, and you can do the math, it's how do we make that proposition feasible in any way, shape or form? So one of the things that you might want to do is prioritize those in terms of things like their DALIs, so I'll explain that term in a moment, or policy priority, and we've done both. So we took all of those 176 and plotted them well, we clustered them into logical groupings, so all flaviviruses together, for example. So you won't see 176 different circles on there. There are I think, about 20 different clusters, of which there are different numbers that indicated by the circle size, with burden, effectively DALYs, on the y-axis and mean policy priority on the x-axis, and I'll explain both of those in a minute. So a DALY is a disability-adjusted life year, and for the purposes of this talk, it's simply a lifetime expectation of disease, of morbidity and mortality over a population attributable to a particular disease. So the more DALYs, the worse. Mean policy priority was an index that we came up with that looked at, for each of these diseases, whether they were on donor or NGO target lists, whether they're notifiable by status or region, and their literature-based H-index. And if you put those all on a graph like that, you can see that the big five in the top right, diarrhea, pneumonia, malaria, HIV, and TB, have big policy and research interest for everyone, and they have a huge DALY burden in the world. So there's a clear rationale that you would prioritize those over the rest. And then as you move forward, you can see, and we can go in on the next slide to look at how that list of 176 can then be prioritized. And that's exactly what we did in that paper. So then if you look at those, if you take all 176, obviously that would be 100% of all mappable DALYs. But if you take the top 45, that's 97%. And the top 10 infectious disease clusters have 95%. So they're a set of diseases that we are prioritizing in this way. And the big five we're giving particular attention in a different type of mapping, and that's for another talk. But the thing that I want to mention here is for pandemic preparedness, for Ebola or Zika, for example, none of those would have appeared in this, or Zika particularly, wouldn't have appeared in that 350, let alone this list. So if you go into a prioritizing exercise like this, you're not going to be able to get all of those particular diseases. So we need to have something that we can scale up, is very, very quick, and can be deployed in pandemic situations, and in peacetime, if you like, when we're not in an emergency, we can go through this back catalogue of diseases and improve our geospatial reconnaissance of all of them as we move forward. So this is our idea, and in fact prototype for doing this, and you'll see that same schematic again, which is why I took a little bit of time on it at the start. And essentially the ideas of the BRAID, the Atlas for Baseline Risk Assessment for Infectious Diseases, are threefold. So we'd like to automate the data retrieval at the start. So this thing that takes us a year to get all of that information takes us a year because we have to essentially manually take information from GenBank and PubMed and sources like that, high provenance information, but it takes a lot of time to gather. As you come along, if you look at those three icons at the top and you move from health map to the Facebook and the Twitter icons, this will move on to in just a moment. But I think there are other sources of low provenance or lower provenance information that we can bind into this work, and much more high volume. And this is where I think there is an opportunity for big data, and I'll talk about that in the next slide. I also think we have a way here to engage with crowdsourcing information. So once we have that occurrence data from these lower provenance sources, we can set up a system whereby experts can look at those data and check that they're in the right place, and we can feed that back into our machine learning and ever increase the provenance of that. And we can also get them to help with, once the maps are created, are they feasible? Do they pass the laugh test in your part of the world? And then finally, one of the problems with all of the mapping that we do is once our attention has passed on a particular disease, for dengue example, we published that in 2013 and made the burden estimates that go with that. There's been lots of movement and change in the distribution of dengue from them. We haven't kept up to date. How do we do that? How do we keep this real and live in real time? And again, this is another arm of the idea of a braid. So the prototype for this is now complete. So we have a system. It's not launched publicly yet, but we have a system whereby large volumes of information can come in and we can crowdsource it. That crowdsourcing at the moment is within our research group, so it hasn't been deployed. But we have a mechanism whereby both the A part of that schematic and the occurrence data can be looked at with its provenance, and people check that it's in the right place and jitter those for us. So if we're able to convince the public health community and the lay public that this is an interesting thing to do, we could crowdsource a lot of information here and a lot of validation. And we have a system now where all of the techniques that we use in species distribution modeling, we can do on the fly. So we've recoded that. This is not Google-esque in the sense that it's not a brilliant bit of software that's ready to deploy to the world, but it's a proof of principle, and we can now, for about 10 different diseases, keep those live in real time, and the new updates of those maps, like this dengue one, gets triggered, and we'll be launching that sometime this year. So once we have a disease in the system, it will always be up to date and always be kept contemporary. And here's my sort of take for opportunity, where I think there is real potential in disease mapping space. And I use Twitter here as an example, and I'm going to set off this next movie again, because the next movie addresses one of the main critiques that I have in this domain of this, when people hear about this opportunity. So we have great provenance data from GenBank and PubMed and these occurrence sources that we can get. But we all know that, and we're using Twitter as an example here, that there are many other social media venues that would provide or potentially provide useful occurrence information. So this is an example of, it's run for 7 hours. I couldn't get it to run for longer than 7 hours, from TweetPing, and you get a snapshot every minute. My figures are probably out of date. If there's anybody from Twitter in the room, I do, or online, I do beg your pardon. But when I last looked at this, about more than 150 million a day, of which 5% were geopositioned and always increasing. The challenge that I always get when we say about, would useful occurrence data be found in these, is people say, well, that might be, but of all the infectious diseases that you're worried about, people aren't tweeting about those in the areas of concern. Well, if you look around this map, I would accept that for this 7 hours in the middle of the Sahara, but for large parts of Asia and certainly for large parts of the Americas, that's simply not true. It's a very, very active community in this, and I would suspect that that would be very true of the other social media sources as well. So my assumption is that there are lots and lots of really good occurrence data in here, which we couldn't ever replace the high provenance surveillance data that we get from public health agencies and researchers, but could be a very useful, with appropriate data fusion and having a whole bevy of people helping extract signal from noise in these data, could take us to a place where we can get the fuel to drive many of these, finding the occurrence data for many of these infectious diseases for which our geographical distribution or knowledge of them is particularly poor. So I wanted to finish with one example, which is, I told you for dengue back in 2013, it took us a year to do. Well, this is a little bit of a cheat, I'll say that at the start, because Zika obviously has many of similarities to dengue which we could leverage in this particular model, but it took us a month to do Zika. So we've gone from about a year for one disease for a month with this system, and people will use this map to make estimates like given a certain flight volume, where a traveler's at risk, or where would they be around the planet. That's my timer telling me that I'm stopped, which is good because this is my penultimate slide. And we can now push these in public health emergencies it took us about 2 months in the last Ebola one. It's about a month for this one, and I think that trajectory is on the right path. And as I say, I think big data is the way that we can speed this up, both for pandemic preparedness, finding those distribution maps, and providing those to the communities that need, but also to inroad into, if you remember that white circle where we have the small area of black, essentially filling that landscape of our geographical knowledge across all of these diseases. So I thank you there for the Bill and Melinda Gates Foundation and the Paul G. Allen Ebola program that have started and continue to support this work. And of course, I represent part of a team, all of whom's smiley faces are there. Thank you very much.